Hello everyone, my name is Dr. Sahil Sabharwal, and today we are going to talk about gastric emphysema and contrast it with a very similar pathology, emphysematous gastritis. In addition, we will also discuss a case of gastric emphysema that I recently saw in the hospital. So first of all though, what is gastric emphysema? Gastric emphysema is defined as simply gas within the gastric wall that is secondary to extreme stress or pressure on the gastric wall. It is a benign condition with a low mortality rate, and it is associated with gastric outlet obstruction, cardiopulmonary resuscitation, NG tube placement, and excessive vomiting. Overall, though, there are only a few published cases on the matter, but cases are most often self-limiting and have resolved with conservative management. Emphysematous gastritis, on the other hand, is due to gas-forming microorganisms such as Staph aureus and the Clostridium species that can cause intramural gas formation and subsequent gastric inflammation. The patient will present with abdominal pain, fever, nausea, and vomiting. Some predisposing factors include recent abdominal surgery, long-term NSAID or corticosteroid use, renal failure, or a history of diabetes. Now, to contrast it with gastric emphysema, which actually has a good prognosis, the prognosis for emphysematous gastritis is fairly poor, with a reported mortality of greater than 50%. This large gap in mortality is actually why differentiating between these two diseases is so crucial. So now that we have actually defined the two conditions though, let's talk about a real-life example. So we have an 86-year-old woman who presented to the ED with intractable bloody emesis. Her labs were significant for a mildly elevated white count, and CT scan of the abdomen and pelvis showed large amounts of gas in the stomach wall, which can be seen here in figure 1. Our initial concerns were for emphysematous gastritis. Now, due to the deadly prognosis of this condition, we immediately started the patient on broad-spectrum antibiotics, and general surgery was urgently consulted, and they recommended the placement of an NG tube. A PPI drip was subsequently added, and both the surgery and medicine teams were closely following this patient's clinical course. Luckily though, the patient's white count did normalize with volume expansion, and the patient denied any further episodes of vomiting or subjective or objective abdominal pain. Soon after, the antibiotics were discontinued, and the NG tube was clipped, and we advanced the patient's diet as tolerated. The patient recovered well and was luckily discharged soon after. Now, given this patient's benign course and her rapid return to baseline, along with a history of retching, the diagnosis was actually changed from emphysematous gastritis to gastric emphysema. Now, there's little literature on both conditions, but what we do know is that for emphysematous gastritis, an urgent diagnosis is crucial and requires urgent surgical consultation and initiation of broad-spectrum antibiotics, which are all actions that we did execute. Surgery may be required in patients with emphysematous gastritis if the patient is severely ill on presentation. However, in both emphysematous gastritis and gastric emphysema, medical management is the preferred treatment route. Thankfully, this patient recovered fairly quickly with medical management, which allowed us to comfortably adjust our diagnosis from emphysematous gastritis to gastric emphysema and discharge her soon after. Now, this concludes my presentation, and thank you all for your attention, and please feel free to reach out if you have any further questions. Thank you.